Hello, and welcome to another episode of Boundless Body Radio. I'm your host, Casey Ruff, and today we have another amazing guest to introduce to you now. Dr. Mariela Glandt, trained as an internist at Harvard and an endocrinologist at Columbia, has more than 2 decades of experience in the treatment of diabetes and chronic disease. Several years ago, she discovered the growing low carbohydrate movement, and based on what she was learning and observing, she decided to change her approach to the treatment of diabetes. She is the founder and director of Glandt Center for Diabetes Care in Tel Aviv, which specializes in optimization of diabetes care through use of a very low carbohydrate diet. Dr. Glandt is involved in clinical trials, actively publishes articles in medical journals, gives lectures in Israel and abroad, and teaches medical residents at Bronx Hospital in New York. She is also the co-founder of Eatsane, which makes low carbohydrate food products with no artificial sweeteners. Dr. Mariela Glandt was a presenter at Low Carb Denver 2023 and did an amazing job presenting her talk titled Treating Diabetes Requires a Whole New Paradigm, which will be the focus of our chat today. I met Dr. Glandt in person at that amazing conference, and it is such an honor to welcome her to Balanced Body Radio. Dr. Glandt, welcome.
I'm honored. Thanks for
Honored to
inviting me.
host you. Honored to host you. It was such an amazing time to listen to your talk, which I found absolutely inspiring. Those conferences are so fun. Maybe the audience is getting sick of me talking about it, but I don't care because I'm still so lit up 2 weeks after getting home. And
I know it's amazing.
it's amazing. It's so cool to be in a room of 1,000 people. I always sit in the front row like a nerd, just trying to take as many notes as I can because I'm trying to learn as much as possible. And like the speakers just come off stage and they sit right next to you like you did. And it's like, wow, you're a little starstruck. It's so cool.
Well, it's an amazing conference. Everybody there is doing amazing stuff, and part of this grassroots movement and contributing to the message that we're trying to bring. So it really is an invigorating experience.
Yeah.
For me, I think of it as like just about the most fun thing I do. More than traveling to exotic places. Like this is where it's at.
Yeah,
So,
I love that. Contrast that to some of the other medical conferences you've been to. How are they different?
oh, it's just the energy, the energy and the audience is just so into it, and it's just everybody's like hungry for every bit of information and hungry to learn every detail because there's so many nuances to this. And I think there's such a drive to, once you've seen it, you can't unsee it, as we say in this movement, right? Because once you've treated patients in this new way, it's so much, you actually feel like you're really making a difference. And because we are a little bit outsiders still, even though we are completely mainstream science, but we're still considered outsiders. This bonding brings us together, which kind of makes it seem like a cult, but it's not a cult. Cults are not based on science. We are,
Yeah.
So I think that there's nothing like these conferences for me.
Yeah, that's fantastic. Well, Mariela is a really beautiful name, and I was wondering if it was Brazilian, but it actually is Argentinian. Is that correct?
Correct. It's Argentinian.
Wow.
It's
And
a
you also have a Jewish background. Is that right?
Yes, my four grandparents are from Eastern Europe and came to Argentina after World War One, between the wars. And there's a large Jewish community in Argentina. And
Yeah.
then I became the wandering Jew going around from country to country.
Wow, that's fantastic. Yeah, I lived in the southern part of Brazil for 2 years, and it
Oh,
was amazing. I felt like I got off the bus in the wrong continent. Like everything was German. Blonde white dude walking around Brazil, but I fit right in. They used to call me Polacco, which means Polish person.
right.
And so it is interesting. There's a huge cohort of people that fled Europe and Japan and settled in that part of South America. Really interesting.
Oh, that is really interesting. Yeah, I didn't know about the Japan part, but
Yeah.
yeah.
Yeah, it was a state right above me that was primarily Japanese immigrants that left Japan right before the war. And so, yeah, just a really interesting history down there. I hope you still claim Argentina as your country after they just won the World Cup so you can celebrate
Oh, are
that.
you kidding? I went nuts.
Ah, heartbreaking for me, but I'm really happy for you.
It was, oh my God. No words to explain it. It's not rational.
Yeah.
It's not something that you can explain because, getting a ball into a goal. That's about what we're talking about. It can drive millions of people crazy, but
Totally.
you can't help yourself.
Yeah,
It's,
totally. Oh, that's fantastic. Yeah, the game itself went all the way down to the wire, went to kicks at the end. It was just so exciting to watch. So again, it was a little heartbreaking, but really happy for Argentina. That's great. Glad you got to celebrate.
yeah, well, I appreciate your good vibes because it was just the best. And poor Argentina, they needed this. They
Yeah, they
really,
did.
really need this.
They did
They're,
for sure.
you know, but
Yeah,
also it's super fun to be an Argentine fan because the songs and the cheers, they're like no other country. The way that the passion that evokes, I haven't seen that anywhere else. Like
it's
so,
so awesome. Yeah, when I was down there in Brazil, if the two countries were playing each other, like you couldn't do
yeah.
anything. You're watching the game. Everybody's watching the game. Like nobody's in the streets. Like
Yeah.
so
Brazil
focused.
is Brazil is a good example for the same type of passion. But yes.
Totally, totally. Okay, so how did you start to get interested in health, and when did you decide you wanted to be a doctor?
Oh, great question. I think it was like a confluence of things. My First of all, my dad is a type 1 diabetic. So I grew up with this always in my house and always paid more attention to anything to do with diabetes. And it actually really helps me in dealing with patients because I know what it's like to go through these ups and downs that are a part of life for a type 1. I mean, when I grew up, my dad didn't have a glucometer. It was horrible. And today he's 76 with no complications.
Wow, that's
Right?
fantastic.
It's really unbelievable. And we're so that was one thing. I think my personality also really fits medicine. I like taking care of people and I love science, but it was just like a natural combination. And I particularly like taking care of people long term. So I was definitely not going to be a surgeon because I'm really horrible in the OR. And 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 I think the last thing, no question, is that my sister had cancer when she was 11. And I think that whole experience of being in the hospital for a full year with her, going in for chemo like every few months, no, not every few weeks, I mean, was, I guess, had a much bigger impact on me than I imagined. So it
Yeah,
was,
wow.
I think, the combination of these three things.
Yeah, that's a lot of really good reasons. And I think a lot of doctors feel the same way. We got into this because we wanted to help people. So, what was it like when you started to practice? Were you able to help people?
Well, you think you help people, right? I mean, I think most doctors are doing their best, and I think I was doing my best as well. I presented that case at the conference because this is like a really typical patient where he was a patient of mine before I started practicing medicine, and you think you're doing the right thing. You give them a lot of meds, you treat them with insulin, you treat them with everything at your disposal. And there are certain criteria that you meet that makes you a successful doctor. Is the LDL where it should be? Is the sugar where it should be? Is the blood pressure where it should be? So if you meet all those criteria by the regular standards, you think you're doing a good job. So, this is, I think people are in general, feel like they have tools, but what we're really doing is we're managing disease. This is what we do. We, as practitioners, we don't really treat. We mostly manage. I mean, surgeons, I think, probably do treat. Infectious diseases do treat. But most of internal medicine is kind of maintaining or managing and hoping things won't get worse. But I think the beauty that happens when you discover that you can treat the root cause is that things actually get better. And because because you're treating the root cause, and the root cause manifests as so many different things. When you are treating the sugar with low carb, you're also treating their mood. You also treat their skin. You also treat their joints. You treat their sleep, all these other things that improve as kind of a side effect of your treatment for diabetes. So it's a completely different thing.
Yeah, it's really remarkable. So you mentioned that case, and I'm so glad you put his picture in there. You refer to him as HK, and it shows his starting point. Now, am I safe to assume that that would have been nearly like a best case scenario in the conventional way of treating diabetes? Like you said, you're managing symptoms, you're trying to hit markers. You showed the laundry list of different medications that he was on, and you did show some of his markers, and they were okay, somewhat controlled. Would that have been the best case scenario of somebody in the conventional system before you change your understanding of treating the disease?
Yeah, I believe so, because this was the guy we were talking about had 30 years of diabetes. And this is one of the things that, because I have a specialty practice, because I'm an endocrinologist, I usually see people, actually, I just looked at the data. On average, they've had diabetes for 11 years before they come and see me. So they are more advanced. Like this guy had 30 years. So it's, there's quite a range, but a lot of people have had diabetes for a long time. And 30, 35 years. And at that point, you need a whole bunch of medications to manage diabetes. Because, at the beginning of diabetes, insulin is really high, but then diabetes presents when insulin levels start to drop because the pancreas can't keep up with that demand, right? But over time, it drops and drops and drops. And that's when we have to treat with insulin in the conventional treatment. So, treating with insulin becomes kind of like this, the normal, the standard for people who've had diabetes for such long standing, for so long. So that's not going to be enough. And I definitely understand that even before in my dive into low carb, I understood you got to also treat the insulin resistance so you could minimize the amount of insulin. Because nobody likes to take insulin, and insulin makes you gain weight, makes you hungry. It's a pain in the butt. You have to check your sugars all the time. You have to inject yourself. It puts you on a roller coaster of ups and downs. And so, this guy was actually being treated with insulin once, long acting insulin, an insulin shot every time he ate. And by the way, 25% of people in the United States are treated on insulin. Okay, that's a lot of people.
25% of the total population.
Of the population of diabetics, yes.
Got it. Wow.
Yeah. So it's of type 2 diabetics. Then this guy was on a GLP-1 agonist, which is, today is the big hit like Ozempic. He was on Jardiance, also a very popular drug today, which lowers sugar through the urine. And he was on metformin, and he was on Actos, which is now a less popular drug, but it's a drug that can be very helpful. So that's a lot of meds for just the sugar, never mind all the other things, right? Because we treat each symptom differently. We treat the blood pressure, 3 medications. We treat the cholesterol. We treat everything, the pains and the benign prostatic hypertrophy and blah, blah, blah. So the gastrointestinal disease, all of this needs a treatment. So we treat all of the symptoms with different meds. That's modern medicine.
Wow. And you also hear that so many of the prescriptions we're writing are also to deal with the side effects of the drugs that have direct relationships to the actual disease. Were there lots of those as well?
One more time, meaning that
it seems like a lot of the prescriptions we're writing are not just to deal with the direct disease that we're dealing with, but the drugs are being written to deal with side effects that came from the medications to begin with. Was there a lot of that going on as well?
In this case, not so much. Okay, but he, even without that, I think he was like on 12 meds.
Wow.
And but in this particular case, not so much, because I'm trying to think of, no, not that I can think of, but it does often happen.
Yeah, gotcha. Okay, so we're dealing with all of these symptoms, and we're thinking that we're doing a really good job with this person. This is the standard classic care. When did you start to come across low carbohydrate diets and realize there might be a shift in paradigms?
I was really lucky to have a best friend who had a website called sweetlife.org. It was a nonprofit, and I was the medical director for it. But funny enough, it started out like a traditional medical diabetes website, because she and her husband both had type 1, and it was an informational website. But what happened is that they started evolving over the years, and they discovered the low carb movement way before I did. And they were, telling me about it. And I was like, "Ah, of course you should treat low carb. And, of course you should avoid carbs." But because intuitively that makes sense. And I was working way back in there in the Bronx, and of course telling people to get off rice and think intuitive. But there's a really big difference between saying low carb and understanding all of the implications of that for real, right? And there's also a very big difference between saying low carb and keto, because keto is a whole other ballgame. So, one thing, and then two patients at the same time sent to me. And anyway, what I'm saying is, like, I feel bad to this day that I kind of like ignored her for a while. Not ignored her, that's definitely not the word, but I just didn't understand the complexity of what she was saying, because I was like, yes, it makes sense, but you don't understand the layers that this implies. And then two patients sent me the Sarah Hallberg video, how to reverse diabetes by ignoring the guidelines. And wow, she was such an influence in my life. I think she's sorely missed, and she was an amazing person. And I owe her so much, actually, for really opening my eyes. And what I needed was a doctor to say it's okay. Like you needed, you don't want to feel like you're crazy. And when you have another doctor say, I'm doing this with my patients, and wow, I'm getting great results, it really had an impact on me. And then it really gave me a lot of confidence, which is one of the things I really want to do now, which is I want to empower doctors to take the leap, because I think a lot of people see the reasoning behind this and get it, but to take the leap, to go against convention, is a really hard thing to do.
It is.
And you need a lot of tools to do that. So, I was very, very lucky that I had just opened my own diabetes center, and I had freedom. I was by myself. I did not have an institution telling me what to do, because I was in Israel, and I was kind of a little bit doing my, because my Hebrew, when I arrived, was non-existent, and I learned Hebrew. I now work all day in Hebrew, but like at the time. So anyway, I like kind of started my own thing, and it really, actually before that, I worked in a private diabetes center too, but there I was like a conventional clinic. But what that clinic taught me is how to follow patients carefully, how to do it right, how to do the teamwork. Because I was the director there, and I was able to learn a lot about that. But I didn't have the technique right. I had all the outside, but I didn't have the meat of no pun intended. I didn't have the actual, the treatment was wrong. Or mostly wrong. We did some things right, but so because I was on my own, it was an amazing experience to just really do what you think is right. Of course, I had to go through a real revolution first, and that took me about a year, because I had to read and feel like, you have a lot of responsibility when you're going to go against convention. Yeah. And I did, accrue quite a bit of enemies, which is fine, because that's the way it is.
That's amazing. I mean, my resistance was probably a little bit similar when I started to learn about this and hear about this. It's like, if I accept this as truth, it feels like it could be true. But if I accept this, everything else I've been taught is wrong. And how you reconcile that is really tough. And I I experienced that with low carbohydrate diets and especially with carnivore diets. The first time I heard about it, I thought it was preposterous and I set it to the side and didn't really do much with it for several months until I started to realize like this message is too important and needs to get out. And most of the people I coach today, they need that same thing. Like you said, they need validation. They think they found it, but they're not sure, and they just need permission. They need validation to say, like, no, it's okay. You can do this. We'll support
Right.
you, but yes, this is okay. Like you're not going to kill yourself, and you will go number two again sometime in the rest of your life. Like they just need permission.
I agree. I agree. It's a real, as it's just, it feels really weird to be the odd one, to be the, especially when when everybody's going vegan, it's such a powerful movement, the vegan, and there's such a desire to kill this movement. I mean, I couldn't believe it this week, that paper that came out that was all over the news when it hasn't even been published yet, about the ketogenic diet causing, increased mortality or whatever. I'm like, actually, I barely read it because I was so annoyed by the fact that it was an observational poster that hasn't even been peer reviewed, and they made headlines all over the world based on, a survey, and based on the fact that it wasn't even ketogenic. 25%, calories coming from carbs. I'm like, that's not even, all the healthy user buy, all of the problems of these studies that are doing so much harm. How desperate are they? There's the media and how excited are people to hear that keto is bad for you, that they're putting this on all over. I mean, I can't even tell you the amount of people that reached out to me to ask me, what do I think about this? And I'm like, just ignore it.
The details of that study are horrific. It's like
Yeah,
1,500 people. They take one food frequency questionnaire. What did you eat for the last year on average? 12
right.
years ago. They don't follow it up. So do you think diets maybe change in 12 years? Like everybody eats differently all the time. And yeah, you're right. The percentages that they called keto and keto-like fit. I searched this. They are the same percentage as a double quarter pounder at McDonald's with the bun and all the trimmings. That macro fits what they were
Right. And
studying.
this type of error, or this, this type of problem happens in so many of the trials, right? Remember the Eric trial that came out, I think like 2019, where
Yes.
also it was, huge, but that one was actually published. This, I can't even find the paper. I couldn't, I think it was just like a poster or something, so anyway, it's very, very annoying, but
Yeah.
it just shows you the forces behind this. There's a real desire for, what I think it's jealousy. I think people they wish they could do it, but they can't. So that's why. I mean, that's
I
the only explanation I can think of.
I agree. I agree with you 100%. And the damage that has been done by all of these headlines that people read and don't know how to look into it and don't know how to look at the facts and how the study was conducted are just going to point to the headline and see, I knew it. I knew if I eat eggs and bacon in the morning, I'm going to die of a heart attack. And it was on
Right.
our local 9 o'clock news around here on a very popular outlet. They reported on it. That is so damaging. It's so damaging.
It
You're right. I think they're jealous.
it's so damaging. It's insane. And it's so, as if there's nothing else to report in the world. There's so much going on in the world. But it also goes to show like how people are, like what we eat has become central. It's become so, so confusing. People don't know what to do.
Yeah,
They're
exactly.
really confused.
Yeah. Well,
Which one's
speaking
the worst?
speaking of confusion, we've covered this at every angle imaginable on the show, but I think it's still confusing for people understanding the relationship between glucose and insulin. If you don't mind, can you talk about everything that you've learned about glucose and insulin? And you mentioned, HK being diagnosed, I believe diagnosed diabetic for 30 years. He was actually
Yeah,
diagnosed. Okay, so can we
diagnosed.
talk about so that's the diagnosis. There were issues before then. It's not like the
Correct.
diabetes happened on that day. So can you talk a little bit about the things you've learned about the relationship between insulin and glucose and how our paradigm is wrong in that direction?
Sure. So, I mean, it's amazing. People do confuse insulin and glucose. And so let's go back. Okay. First of all, one of the main things I want people to understand is that diabetes, which by definition is having high glucose, is just a symptom of having high insulin. Okay, so let's start by having that in the background. So what happens is that when we eat the way we eat, which is basically, or we're recommended to eat, or like the food pyramid, which is based on carbohydrates at the base of the pyramid, and about, it varies, but let's say 60% of our diet composed of carbohydrates, and also processed food, including seed oils, which I think are playing more and more of a role here as a potential cause of diabetes, which is really fascinating. And this which is we can touch on this later, but anyway, the cause is still a question mark. Okay, but we know that over time, when we eat the way we eat, okay, the body in a way gets stuffed up. Okay, it cannot store anymore. Now, why is this important? Because insulin is the hormone that's released to help us store. Okay, so it's not released in the same way for every macronutrient. It's released a ton when we eat carbs. It's released a little bit when we eat protein, and much less when we eat fats. So when we eat, if we eat a piece of bread, you're going to have a ton of insulin secreted. And if you have meat, with some fat on it in a salad, it's going to be much, much less. So if I eat a piece of bread, it gets broken down into glucose. Now, glucose is a simple sugar. Okay, bread in particular has more glucose. It has is mostly glucose. If you eat a fruit, it's like glucose and fructose. So things break down into simple sugars, and not all of them behave the same. But let's talk about glucose, okay? Because glucose is the one that really leads to or encourages the pancreas to secrete insulin. So the glucose comes into the blood. The pancreas has ways of sensing this and secretes insulin in response in order to get rid of the glucose as soon as possible. Glucose is toxic to blood cells, okay, to the vessels. You should not have high glucose, and therefore, at the minute sugar goes, there's no tolerance at all for having high glucose in the blood. Immediately, the insulin releases the pancreas releases insulin. Now, protein and fat actually don't really require that much insulin, as we said. So it's okay for this to be less regulated, but glucose is perfectly regulated very, very tightly. So insulin is released and the sugar is taken up by first the muscle, but many other cells in the body, okay? Now, the issue is that the same hormone that takes the glucose down in the blood also does a million other things. And one of the things it does is that it stores fat in the fat cell, okay? So basically, what I think people don't understand is that when I eat a carb, what I'm doing is I'm stimulating the hormone that's going to store this as fat. And that is something that even doctors don't make that connection, okay? And it's really that simple. Insulin stores fat. And the converse is true. I cannot burn fat in the presence of high insulin. So this is really, really, really important, okay? Because if you're eating breakfast, which is cereal, and then 2 hours later, you're eating a fruit, and then with your granola or whatever, and then you're having, this, and all day we're eating and eating and eating, you're secreting a ton and ton of insulin. Now, the more insulin you secrete, the less your body wants to respond to it. Okay, so this is one mechanism by which we get insulin resistance, which means that insulin resistance means that the same piece of bread now will require a ton more insulin to get that out of the blood. All right, so you need more and more insulin to push that sugar in. Okay, because the body doesn't want to respond anymore. Now, it may be because there are many reasons for this, and it's really fascinating to look at all of the different theories, but all of them might be true and work simultaneously. Because, for example, the more insulin you have, there's a downgrading of the receptors, as I just said. There's in the number and in their function, basically the receptors are not working, you can say, okay? It's a kind of a way of protecting the cell that's probably saying, and kind of, I'm giving personality to the cells, but meaning like, enough, I've stored enough, okay? Because what happens is that we have a certain capacity for storage of fat. So first we store fat subcutaneously, and when we run out of space, we start putting it in places where it shouldn't be. And this is called ectopic fat. And as we become fuller and fuller, and ectopic fat is a really bad thing. We do not want fat other than in fat cells, okay? Fat should be in fat cells. We start accumulating fat in places where it shouldn't be, that organ stops working the way it should, okay? So let's take the example of fatty liver. When there's fat in the liver now starts actually working completely different the way it should. For example, liver should respond to insulin by actually storing glycogen, right? Storing glucose and converting it to glycogen, but instead it cranks out sugar. So it cranks out the glucose, and like this, many, many things. So bottom line is that there's this feeling that there's enough. I do not want to store anymore, which is, again, I'm personalizing, my husband gets really mad when I say that, but to me, this is the best way to understand this, right? The cells don't want to respond anymore. They don't want to store anymore. Or, if we look at it like fat in the muscle is stuffed. So the minute you have fat in the muscle, you become insulin resistant at the level of the muscle. And again, this is true also at every organ. So bottom line is that now your pancreas is going to secrete insulin, and it's not going to respond. So it's going to secrete more insulin, and the cells are not going to respond. So the sugar is still in there. Sugar cannot stay in the blood. This is toxic. It must secrete more insulin. To the point that you end up having high insulin all the time, whether you eat and not eat. And now, what does that mean? You're always storing, even if you're not eating, you're still storing fat, which is why people can't lose weight. Okay. Yeah. But taking that one step further, okay, so that's called insulin resistance, right? So when you have high insulin, it's almost synonymous with insulin resistance, which is almost synonymous with metabolic syndrome. These are all difficult words because in the sense that we're kind of repeating ourselves, but it's not exactly the same, but close enough. So bottom line is that you have insulin that's all the time high, and we lost that important balance of secretion and decrease in secretion so that you can use what you stored. And in about 10% of these patients, you have a pancreas that starts to malfunction. Okay, so when the pancreas can't keep up with this amount of insulin, then what happens is that you have a lot of insulin, so you're still insulin resistant, but it's not enough to overcome the resistance because your pancreas is not working, and then you get diabetes. So you need two things to get diabetes: high insulin and high sugar.
Wow.
Does that answer your question? Sorry that it was so long.
It answered the question perfectly and very, very well. Thank you for that explanation. As you're talking, I'm imagining like an episode of Hoarders where people are bringing in stuff into the house. They have shopping addictions or whatever, and they can't throw stuff away. And so normally you could put all of your clothes in one closet, but if you're continuing to shop and shop and shop and buy a bunch of stuff, hoarders end up with way too much stuff in the house, and boxes pile up, and they can hardly like get through the house, and the house is bursting at the seams with all of this crap. And so they'll come in and help the person clean it out, but they also need to have therapy with the people to say, you got to stop shopping, stop bringing more stuff in the house. Otherwise, it's just going to fill right back up again. So on that note,
it's a great analogy. Yeah.
Well, thank you. Let's hear what your different paradigm for treating diabetes is, and how we can fix these problems.
So the way to fix it is to bring down the insulin. So all we have to do is eat foods that don't raise your insulin, which is basically protein and fat. And the more that is an animal-based, I have better results. So we prefer protein and fat And very quickly, insulin levels start to drop, and you have to just be consistent with it, but it happens. And it depends how long we've had this insulin resistance. If it's a couple of years, and it's very reversible. If you've had it for 30 years, like Mr. HK, then we're still gonna need some meds. But the thing about HK, right? So like you said, he was diagnosed 30 years ago, but the insulin resistance starts way earlier, about 20 years earlier, maybe with 6 to 20 years, it depends on the study. But you see the insulin resistance always precedes. You're not going to ever get diabetes without a previous insulin resistance. I'm talking about type 2, of course. Okay. So it's a mandatory, prerequisite to get diabetes. You must have first insulin resistance. So we must treat that first. And that's what we do. There are many ways of doing that. You change the food, you change the timing of the food, you try not to eat at night, you add exercise, which becomes key, especially after about 3 months, it becomes more and more important. You've got to change the sleep, you got to improve the sleep, and all the other things that give us joy and decrease stress and the usual, right? But we start with the food because it's by far the easiest, and also once you do that, when I tell somebody to exercise at the beginning, that's not going to work because they're hoarding energy. How can I ask you to go to the gym? Like, that's ridiculous. But once I started lowering the insulin levels, then, the flip switches. You start burning energy, and you have all this excess energy, and you want to work out, and you want to do stuff with your body because you have energy, right?
Yeah. That's amazing. You had some slides where you presented some of the results that you were seeing in clinic. And it's similar to what we do with personal training and nutrition coaching. We're not running studies. We're not doing trials. These aren't randomized, controlled, whatever. It's just what we're observing and numbers that we're seeing. When people lose weight, we can measure how much fat they're losing. And it's really remarkable. The percentage of total weight that can actually come from fat is actually very, very high. And again, that's more anecdotal, and we're trying to track as best we can, but you're doing the same thing. Can you tell us a little bit about some of the results you're noticing in clinic with treating patients in this way?
Yeah, we have, well, first of all, we have the A1C in our clinic. What I did is we've seen about 3,000 patients by now. And I just looked at 101 patients that I saw that I treated with a nutritionist, so that that I knew had positive ketones at some point during the treatment. And so, it's messy data, right? Because it's a clinic, it's not a trial, but we really did have enough data. And I only took those that I had at time 0 and 6 months data for points. And we saw that, unfortunately, men lose more than women, so women are right to complain about that. There was I think it was 9.7 kilo weight loss for men, and women it was slightly lower. I can't remember exactly the number off the top of my head. The A1C went from an average of 7.8 to, I could pull that up. I'm like totally blanking out right now. I think it was 6.1 after 6 months. We have the triglycerides dropped tremendously, and the HDL went up really beautifully. You know what? I would love to actually be accurate about that. You want me to pull this up for a sec? I could do that. But it's let me see. Here it is. Okay, so yes, and actually we're gonna publish this data. And on the weight loss overall for the clinic was 90 kilos to 82.9. The systolic blood pressure dropped from 139 to 127. The A1C dropped from 7.8 to 6.2. The plasma triglycerides from 214 to 131. And the HDL rose from 43 to 52, which is my favorite because people don't think that that's possible. And what I think is also really cool is that about more than a quarter of my patients were on insulin when they started, and only one of them was on insulin at the end.
Incredible.
So I think it's all of these improvements happen in spite of the fact that we decreased medications. And yeah, a lot of people ended up with no medications. So we're actually looking this weekend. I'm gonna work on fine tuning this, because I think we should publish it because you know why? Because I don't think there's any data published in this type of population. And I think the more clinics that publish, the better, since it is so hard to get randomized control trials. Although we are doing a randomized control trial in West Virginia,
Oh, wow.
using Ona Health, which is now my baby. I'm working really hard to bring this out to the medical community, to more doctors, making this technique available, this way of treatment easier to implement in your practices. And so we're looking for nurse practitioners and doctors who are interested in practicing low carb, and also coaches that are practicing low carb. And we provide the it's a combination of doctor, mentor, or coach, and the platform. And there's a app for the patient and an app for the doctor and the coach. And the patient, and it's a medical treatment, so that that because of that there is a doctor, because I think many times it is important to have the doctor involved, especially in the sicker patients. Not everyone needs a doctor, but one of my goals is to bring this into standard medicine. Like I don't want this to be in the fringes. I want doctors to use this. And so the idea is, let's get the patient on there, give them a coach that holds their hand. And every day they're getting a lot of, and the patient gets a menu that's personalized. And we also look at all the issues with sugar addiction up front, to see what kind of path we're going to take with this patient. And then the patient receives education on a daily basis and chats with the doctor and the coach. The doctor is necessary, the coach on a daily basis. And we see their CGM, their data, whatever it is that they're checking, whatever it's decided upon with the doctor they want it to be checked. And that chat is really, really key to really hand holding the patient. And then there are weekly meetings, so there's a sense of community as well. And then after 3 months, you can do labs again. It can be after 6 months, etc. And you check in, and then hopefully patients will continue. Actually, we launched in Israel in October, and it's been fantastic. Just seeing some great results.
What a great idea. I love that platform idea. That's so cool. And you're talking about helping thousands of people, but we always have to bring it down to the person. And HK is a human being. He's a person. And originally your clicker slide advancer on stage wasn't working. And so you showed the after, and it was exactly the same as the before. I was like, dang, I was kind of hoping he would made some progress. And then you clicked over to see the new HK. And oh my goodness, a few medications. Everything else is gone. He's lost a bunch of weight. His blood pressure's way better. Huge amounts of energy. Amazing. That's so cool.
I know. He went, and part of my slide, in a way, the reason why, the point I wanted to make there is that in patients who've had diabetes for so long, I don't consider it a failure to get them off meds completely, because it's going to be really, really tough. Let's be realistic. You've totally destroyed your entire metabolic system for at least 40 years if you had diabetes for 30. So, the fact that this guy went from so many medications to 2, I mean, wow, right? To me, that's exciting. And, as we said, he switches the way he consumes energy to a completely different way. So he's full of energy, goes to the gym, and can't wait to tell the world about it. This is how we're going to succeed one day, right? Because each case gets so excited about their results that they just can't shut up about it.
Wow. Well, tell him thank you from all of us. Tell him thank you from all the participants of Low Carb Denver who got to see him and meet him and cheer him on his journey. Mariela Glandt, I know you have to go. You are globetrotting. You're in Spain right now. You're doing all kinds of different stuff around the world. I know you're very busy. We really, really appreciate you taking the time to spend some time with us today and explain some of these things. I think it's so important. Your slides were very meaningful, and I really appreciated them as well. Tell our audience where they can go to find you and connect with you and your work.
Basically, I would go to our website, OWNA, like owning your health, OWNA.health. And there you can leave your contact info and we'll get in touch. I really, really hope to reach as many practitioners as possible. I think together we can really do a lot, and all of us can use the anonymized data to publish or to do whatever people want to do with this, because we need to really join forces, I think. So it is a great platform to do that.
That's fantastic.
So OWNA.health.
Awesome. We will link that in the show notes. And you're right, this is a grassroots movement. We need the people to have the results, but we also need all the doctors and clinicians to get this information so they can start helping all their people. So again, Dr. Mariela Glandt, thank you so very much for spending time with us today. I really, really appreciate you and appreciate your work.
Thank you so much. You're awesome.
It was such an honor. And this has been another episode of Boundless Body Radio.